Thanks a lot, Bincy. Am I audible first of all? Yeah.
Yeah.
You can hear me. Okay,
Yes,
fine.
yes.
So good evening, one and all present here. First of all, I would like to thank you. Thanks Savita College for this opportunity to talk about neuro rehabilitation, neonatal intensive care unit, the role of occupational therapy intensive care unit. When I given options and Arun sir chosen neonatal ICU, first choice. So that is why I have taken this as no. Uh, I have taken this into two parts because it is a huge topic. Uh, yeah, it's a huge topic. So I have divided. First, let me give you some orientation about neonatal ICU, and then I talk about occupational therapy, maybe in another session actually. So first of all, I the 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 biggest disadvantage of this Zoom is I am not able to see any of your face. So still I try to communicate with you at the end of the session. Okay, I continue my session. The first thing is I am Ganapathy. My introduction is given, and I need the next slide here. Can you please change the slide? Yes. Fine. So I'm not able to see the full thing. So I want to move it. Can I move this side? Yes, that's fine. Right. So you know about ICU. What is ICU? Here we are talking about neonatal ICU. A neonate is from the birth to 28 days. It is called neonate. So the definition of neonatal ICU is, it's a book definition, a complex and highly specialized hospital unit designed to care for the infant who are born prematurely and are critically ill. So when I was thinking about this topic, I thought, okay, sir, let me go directly into neonatal ICU and then talk about the role of occupational therapy. Later, I was thinking that if you are doing something, there are people who worked before, years back. They have sacrificed their whole life to create the scenario happening now. So that is why I have decided to do the history part and then go detail into this. So can you please move the slide? Next slide, please. Yes. Okay. So I'm going little 300 years back. Actually, it's too far. So in early 17th century, okay, what was happening at that time? The life's most beautiful thing is the child's birth. It's not the child's birth. I'm sorry, it's birth for any animals, any birds, like it's birth. But in yeah, am I okay? I have some sounds. Okay, fine. So any birth, it's the most beautiful experience of human being. In 17th century, the babies who born were given to the family, and they have just directly taken away to home without bothering about what is the condition of the baby. At that time, the infant mortality rate was very, very, very high. Okay, so that time, but this first person who was working with this infant, the infant mortality was around um, around 28 percentage that time. So what they have done, that the person called Turner, the Turner, he has created something called an incubator. So he understood the preterm infants are the preterm is the main reason for mortality rate in infants. So I have to tell you what is preterm, right? So the term baby is from the birth to 40 weeks, usually the term is given to given to us. This I consider as full term baby. 37 is considered like clinically, you can say the baby is full term. So any baby who born before 37 week is considered as preterm babies. So these preterm babies are associated with low birth weight. Since the low birth weight, because of that, they have poor fat, no subcutaneous fat tissues. They cannot tolerate the cold outside. They develop something called cold stress complication leads to death. So this Turner is a person who first identified this and created a incubator. We all know, like we call incubator, the baby is kept in incubator, right? So he created an incubator, which is a crude wooden incubator. He kept the babies inside and observed how the babies are surviving. And he got this idea, where he got this idea from. It is from the poultry farms where they hatch eggs and chicks under the heat. So he understood the heat is the primary thing for the baby's better survival. Then he created the crude incubator. Then comes the second person, Budin. I'm sorry, the pronunciation maybe like he's all French people. The pronunciation may be a little different. You can see, go through the Google and find out what is the proper pronunciation. So his name is Dr. Perry Budin. In 1893, he is basically a obstetrician. So he is the pioneer of neonatology. In perinatology, he is called father of perinatology because he invented this gavage system. That gavage is basically the process of using tubes to feed the babies and improve their nutritional status and make them survive. So he is called father of modern perinatology. And he next, followed by that, is a one person called Martin Cuny. He is a very interesting person because in that time when the babies are died, nobody was bothered. Do we have to do something about it or just leave it? Because number of babies death was so high. So Coney was not happy about that. So he has taken his crude wooden incubator, Turner's crude wooden incubator, one step ahead. And he wanted to create a public awareness that keeping the babies in the incubator is increasing the survival rate. So what he has done is he exhibited the babies incubator, baby who are incubated. He exhibited in public places so that everybody will come and see what is happening to these babies. But this person faced lots of difficulties. No, he faced lots of challenge doing this. People thought you are doing it for you are doing it for the sake of money. That is what people thought. But of course, he was doing it for the sake of money, for improving the quality of infants. So he displayed the baby, and people who come and see the babies, the preterm babies kept in incubator, no heat is administered, all these things people started seeing. And then these things, they also the nurses who carry the babies and they remove their rings and put in baby's hand and show how thin the baby is, and they cuddle the baby, which they made it like a show. So later, means 1950s, the time of 1950s, people started accepting this as one of the treatment modality for preterm babies. And of course, it is increasing the survival rate of the preterm infants. So Martin Cuny faced lots of other challenges also. basically he had some controversies related to he's not a medical person, but no, he's not having a qualified degree. But the idea he created, and he achieved a great thing for that. In 1950 he passed away, followed by so till then the heat was the major thing to make the baby survival. And then followed by that, Hess came. His name is Dr. Julian Hess. So Julian Hess is he added one more thing along with the along with the heat. He added humidity and also supply of oxygen. Will He thought that a supply of oxygen should improve the quality of the baby's survival. The survival should increase because of administration of oxygen. And also he made the crude wooden incubator into a, transparent uh, proper, you can see from outside a proper incubator. He is the one he created that. That is, his name is Julian Hess. And the next person came is Robert Boer. He added, along with heat, humidity, oxygen, and ease accessibility of this whole incubator, because earlier it was a closed box, and later he developed some accessibility so that the care can be given to the preterm infants very easily. So that time around World War II, there is a system called specialized care baby unit was started. So here in 1950 to 1970s, there is a huge change in the what do you say? 1 minute. It's not coming down. There is a huge change in the way of care to this at-risk infants. And the next person who came was Louis. This is again another interesting story about Louis. What he has understood is, earlier days they were keeping the babies in one room, means separate rooms, isolated cubicles, so that the infections will not be spread to the another infant. But what he observed is the cleanliness. The infection is not transmitted from one infant to another infant, but it is transmitted to adult. That is when the cleanliness came into picture. He made all the infants into one room and made that as an unit, and made it more clean and restricted for visitors. And also he emphasized on cleanliness and hand hygiene. I don't, sorry, we don't believe that it took almost 10 years to understand that hand hygiene is one reason, because the babies are, no, the mortality rate is high because of the we call nosocomial infection, which is transmitted from one person to others, or baby to other through hand. That is where he emphasized the use of no sanitary sanitation technique. What we are doing, like different steps to clean our hand now. He emphasized that. He also done some experiment. He used around 25 um, thousands of babies. He divided it into two groups, and one group is washed, another group is not washed. And then he found that the babies who washed and kept clean, the survival rate is high. But even before he complete his research, people started accepting that hand hygiene and visitor restrictions and cleanliness is very very important. And also he developed something, a test, so that to prevent the infections. He developed a test called LS ratio test. That is lecithin sphygmomyelin test. That is lecithin sphygmomyelin test is done to see what is the quality of the lung. So one of the complication which we see in preterm infants are RDS. RDS means respiratory distress syndrome. So this RDS, he wanted to check this the quality of the lung. So he introduced this particular test, and basically it is taken from amniotic fluid. You take the amniotic fluid and check what is the fetal lungs immunity. That is one huge change he has made. So Dr. Lewis became the father of neonatology. Can you please change the slide? Yeah, great. So after these stories, until 1970s, the emphasis were given more towards the environment, cleanliness, infections, and incubators like machines, right? Then came Haley's Als. So Haley's Als entry into neonatology made a huge paradigm shift of looking at in a different aspect how we can make the survival rate of the preterm infant much more better. So how he has done is when he entered into neonatology, he has done something called newborn individualized developmental care and assessment program. So in that he understood apart from the machine, the emotional aspect of the child development is very important, where he put the child's very close to mother, skin to skin contact, and the warmth and the smell. All these things are making a huge difference in the survival rate of these infants. So he made, in earlier days, what happened, the parents were not allowed inside the NICU, but later the mother was taken inside for kangaroo care, and also the father become visitor. That means that he is a part of the treatment. That is for the students. Like if I'm going very no very fast or too slow, please let me know, because I'm not getting any kind of feedback. I cannot see your faces. So I'm sorry for that. So please let me know, any one of you, if I'm going very fast or too much for you. Okay, because I prepared these slides keeping the students in mind first of all, and then for others. The second thing is like yeah, kangaroo care. Initially, I was thinking about it's kangaroo mother care, KMC, and then later I was thinking about it's like KFC, and it's basically the keeping the babies in between the breast of mother or father, so that the baby will be in a warm, protected environment. I would always suggest a few things you have to refer when you are go through these things. Like here, I would suggest that what is the function of the sympathetic and parasympathetic nervous system in child or adult development. What is the role of this? Like basically, the sympathetic nervous system is the activating system. Like it increase the palpation and is make you more active and ready for fight response, fight or flight. But the parasympathetic nervous system is one which relax and calm down and make you more comfortable and consoled. Because the preterm infants are like like they are very irritated because of this environmental disparity we will see in the next part. Basically, the difference between the intra inside the womb and the outside womb, all the sensory system receive the different kind of sensation when you compare inside the womb and outside the womb. For example, if you take inside womb, it is very warm, and the fluid will give you a very smooth oscillatory movements. But outside, it is like the handling is very hard, and the baby is like has to move their body against the resistance of the gravity, and that is cold outside. These differences are kept in mind and created the care. So kangaroo care is another milestone of a better improvement of the child's development, infant survival and development, mainly for emotional things. That's why like we cannot. We have in our culture, like you carry the baby all the time, closer to the breast, and they get the smell and get attached to that, because smell is very closer to that, to your deeper part of the brain, like hippocampus and the emotional areas. So that is a important thing to mention here. And the next thing is parent rooming. This is another important milestone of NICU. It's parent rooming. That means parents are no more outsiders. They are the part of neonatal ICU care. So they have taken in often and given care through parents was administered. Basically, KMCH, not everything. The KMCH is an important thing. The second thing, and then the next thing is that time is you got that uh, family centered resources and support system, and the extended family support system developed drastically. So in our scenario in 1990s, so the increased technology, the amount of technology is increased so well in neonatal ICU, that brought that to the extent of actually, as for my understanding, around 26-week baby, 26 baby, we can make the baby survive in neonatal ICU. But the technology has brought the up to 23 week gestational age. Gestational age is basically the baby born. Okay, there are different classification and terminologies which the students may not be aware. Basically, the gestational age is when the child born. So 23 week gestation means that from the conception 23 weeks. We can also call it post conceptual age, since 37 is the normal term. uh, 23 weeks born baby, we can call it post conceptual age at 23. These details I will explain you during the next session. So the point is the increased technology has made 23-week baby survive, which was imagined like which was about 500 grams, that is half kg baby. Normally, we expect around 2.5 kg to 3 kg, consider as normal baby. The growth and technology in NICU brought this level. That is the good thing. Personally, I have handled 26-week gestation, the weight of around 600 grams. But imagine the baby was in NICU for about 7 months. So you can imagine the amount of burden the parents undergone, and also the financial load on the parents are huge. Actually, the family has to face a huge financial load. That is the situation here, right? And when we talk about Indian system, right? So in India, there are lots of shortcomings that which we will discuss. What we are talking about is the history part, how this NICU developed. We can go to the next slide. Yeah. So there are facts. Why I am telling this, like we can directly jump into that, but we, if we know about it, we know like what we are trying to do in this situation. Like in this situation, as an occupational therapist, how we can contribute to make the baby's life much better. That is the first priority. That's why I am telling all these things. So of the 15 million babies born preterm globally, 1 by 5 are born in India. So that is like 1 by 5 is the huge number actually. So India, however, has the highest number of first day death and stillbirth. Stillbirth is like babies who born dead. So India is the highest number. And the principal cause of neonatal mortality in India are sepsis, perinatal asphyxia, a difficulty in breathing, and prematurity. These are the three major cause of death in India. Then comes that globally, newborn health is now considered as a highly national priority. So they have made a statement in India. They have made a statement that about 2013, the infant mortality rate was about uh, 28 percentage 28 percentage. So they have brought it about no 9 percentage in 2030. They have to reduce. That is the commitment they have taken. Means the National Neonatology Forum has taken the commitment to reduce the neonatal mortality rate up to 9 percentage in 2030. So you can see the last line that the current neonatal and infant mortality rate in India is 29 per thousand live birth. That is and 42 per thousand live birth respectively. That means that infant neonates are about 29 per thousand, and infants are about 42 per thousand. Next slides. Next slide. Yeah, fine. So, in the last 2.5 decades, has also witnessed an increase in newborn research and its no, in incorporation into medical and paramedical education as a major core of no component. So that is what the Neonatology Forum has played a major role in bringing um, not only the medical people, also the paramedical people, what how to train these nurses, manpower, know how to increase the manpower, how to increase the technology, all these things they are working on that. And unfortunately, there is a deep divide, and the poor rural population is still under served with a lack of even basic newborn care. That is, we have to see, because when we talk about neonatal ICU, this is like a highly sophisticated hospital unit. That is what the definition we have given. But the sophisticated hospital unit also have economic requirement is there. Around 2013, in India, they have estimated 3.5 crore is required to create a average modern neonatal ICU. Now it should be around 3 to 4 times more. But imagine about the village and poor socioeconomic background. So let me talk about the Indian scenario also. Yeah, next slide. Can you move the next slide? Yeah. So before going into the Indian scenario, I just want to tell you that how this NICU and the infants and NICU are classified in India. I give you Indian scenario so that we can extend it and go get understand that what is happening in other countries. So the classification for Indian infants are well infants, high risk infants, and sick infants. So what is well infant? The baby is full term. Okay, he born more than or equal to 37-week gestation, and the birth weight is around, like, you can say that normal birth weight, expected birth weight is around 2.5 kg, that is 2500 grams. And the baby should not have prenatal, perinatal, or postnatal complications, and their vitals appearance should be normal. That is measured by there's some scale called Abgar, and you can search and find out in it. You have to read about it. What is Abgar score? It is done immediately after the birth. So the name Abgar is an no short form of appearance, and next is pulse and the grimaces, activity, and respiration. So we classify that each area is having 0, 1, and 2 scores. If the baby is scored, no, it is done immediately after birth, and 1 minute, and then every 1 minute and 5 minutes, like that, it has to be done. So if the baby is getting the score of around 7 to 8, the baby is absolutely normal. The infant is absolutely normal. If the baby got the score of around 7, 6 to 3, then it is slightly risky. The baby has to be observed again after every minute up to 5 minutes, and or more than that, till the baby get all right, or you have to get back to NICU. And if it is less than 3, then the risk and damage is severe. That is how it is assessed. Then it is about high risk infants. So high risk infants are, it can be preterm, that means before 37 weeks, or post term, that is more than 42 weeks, or 40 or 42 weeks. Means up to 42 weeks we can expect the baby to normal delivery, but more than 42 weeks is considered as post term baby. And then low birth weight, uh, that is less than 2.5 kg, and it can be overweight also, and low Apgar for about a minute, and need, some babies would have undergone for cardiopulmonary resuscitation. And if the mother has a complications during the delivery, and then that also consider as high risk infant. And the infant who are sick and then become normal, that is also considered as high risk infants. And next we talk about the sick infants. The sick infants are basically who had uh, tachycardia, that is the increased heartbeat. Infants, a normal heartbeat is around 120 to 160, we can expect. If the heartbeat is more than 160, then it is called tachycardia in infant, and bradycardia is one, then less than 120, then it is called bradycardia. And also the respiratory rate and patterns are an important sign for sick infants. That is slow and shallow breathing, and irregular respiration, and rapid respiration also cause. And we have more than 60 breathe for, not beat, sorry, breathe per minute is considered as tachypnea. And if they have apnea, that is absence of breath and the resuscitation, and severe apnea, cyanosis, that is cyanosis is like bluish discoloration, then it is called sick infants. So color, again, color of the baby, when we talk about appearance, color of the baby is an important sign whether if the baby is, like, usually the baby born with a pinkish color. If the baby is white, red, blue, yellow, then the baby is considered as sick. If the baby is white, then it is pale baby. And if the baby is red color, then it is called plethoric baby. And if the baby is cyanosed, if it is cyanosed, that is fluid discoloration happened because of you know because of lack of oxygen during birth, because very well that the lungs will not function before birth, and once the baby born, they have to cry so that the lungs start functioning. The baby doesn't cry, then they develop something called cyanosis. And in the cyanosis, you have two different things. One is called as centrally cyanosed, that is the body and the extremity, and the peripherally cyanosed is like only the extremities which will get cyanosed, not the central part of the body. And also the jaundice is another important thing. It's like yellow discoloration. Uh, that is another consideration. And also about the next component is next to color is temperature. So temperature, we spoke quite sufficient information about the temperature, the importance of the temperature for babies. If the baby is having a low temperature, then it is called hypothermia. If the baby is having high temperature, then it is called pyrexia. So these are the classification of the children, infants with infants classification, basically the infant classification. And then we talk about the NICU classification. So when we come to the NICU classification, how the NICU care system is divided, that is what we are talking about. So in India, it is divided into three major classifications. That is level 1, level 2, level 3. So in level 1, more than 1,800 gram baby born 34-week gestation are kept. Basically, these kind of cares can be given at home also, because we usually send the babies. We are expecting the baby to become about 2 kg, so that we can send the baby out, discharge the baby. So this care is like about this is like about 80% of the infant require level 1 care. And next comes the level 2 care is 1200 to 1800 grams require level 2 care, where you need sophisticated equipments to increase the survival rate of the children and infants. 30 to 34-week gestation fit into level 2 care. Approximately about 15% of the infants require this. And level 3 care, it require less than 1200 gram babies require level 3 care. It is like highly advanced and sophisticated, but this is what the maximum possible, like in India. But in other countries, they have a level 4 care where they have all the sophisticated equipment to make the baby survive up to 23 week gestation baby also. If you This is the Indian scenario. Like in India, still we are having problems related to transportation of baby to different places are difficult, and giving high care. And we got the information that if you have to create a NICU area, at least the minimum requirement of NICU area is 100 square feet to 160 square feet for the NICU area. So that is a huge area for any hospitals, so the space is another important factor. uh, and technology and financial status in India is still growing. Some of the hospital of course has, but not up to the primary what do you say that, not exactly the to village population. That is what the point. That if you take UK and US, UK is following almost the same uh, way of care, or no, three levels of care we have, but they have a good manpower and technology, that is advantage. So the first level is special care baby unit, and the second, here one nurse will take care of about four babies. And the second level is local neonatal unit, where the advanced care is given. Here is like 1:2, or 1:1, or 2:1 also sometime given. That means two nurses will take care of one baby. That much manpower is there. That is an advantage. And the third care is that most premature infant who require 1:1 or 2:1 care with advanced equipments. If you take the other US, they have four different levels. Uh, but each country, they have their different way of classifications levels according to their policies. We can go to the next level. Next slide. Yes. So when I talk about this, uh, Indian scenario of neonatal ICU, we have a lack of lots of things till we are looking for a better development, better prognosis in neonatal ICU, to the extent of reaching all over India, even to the village level, the care has to be spread. That is what India is looking forward towards 2030. Why? Because 70% of Indian population are poor. That is why the need for this advancement is mandatory. So now, let us move to the next thing. I was thinking about like what is the present status in India, because this is my personal experience when I went to approach neonatal ICU. Even after working about 8 years in NICU, not as a full-time therapist, but we have a NICU. We go every day and treat, and then follow up in something called neonatal follow-up clinic. But every time when we go to the next hospital, so for example, I tell my experiences from St. John's. I moved to Columbia, Asia. So again, we have to prove ourselves that we can do this. We can show some prognosis in patients. So I have just roughly put this thing for the best outcome for the infant. So I just put infant as a sender. These are the two people, like I can move this cursor here. So these are the two people. One is the neonatologist, and the neonatal nurses are always available in neonatal ICU. They are the mandatory people, and they are like all the time they are with the infants and trained well. And the person comes is obstetric and gynecology. Uh, why obstetric and gynecology is important is because the health of the mother is very, very important for the health of the baby. So when you say mother, it is not after pregnancy, even no, even not after puberty. It's just a mother is born. As a child born, the health of this child from her birth to the delivery, or even after the delivery, is very important for the well-being of the baby. So now the huge change in the food habit, and the what do you say that lifestyle changes has made a huge impact on um, no the problems related to this thing, in spite of advanced technologies. the ratio of preterm infant is still there, and problems related to pregnancy and deliveries are still there. So the health of the female, I call female, and then the mother, the emotion of the mother and the well-being of the mother has to be focused in neonatal ICU. I was talking about this, what is the extent of the care they are looking for is
Hello?
Hello.
Hello, sir?
What happened?
I think it's stuck, sir. I thought it's for me.
Oh,
Okay, just called it.
Jonathan, Morgan Touch.
Sir,
Yeah, what happened?
sir, network problem நினைக்கிறேன். அவருக்கு டிஸ்கனெக்ட் ஆயிட்டாங்க சார்.
Enna, what happened, pa? Can you sign in again? Yeah, you can. Using the same ID, you can log in again. Yeah. Okay.
Jonathan.
சார்,
Father, or just allow.
ஓகேங்க சார்.
We will again log in. Participant, kindly bear with 2 minutes. There is a technical issues, so we are rectifying it.
Hello, Jonathan.
Yes, ma'am.
He's signing in again.
Okay,
let
ma'am.
him in.
Okay, ma'am.
hello.
Yes, sir.
Yeah.
Yes, sir.
Yeah, I can hear.
Okay.
Everybody can hear, no?
Yes, sir.
Yeah.
Yeah,
we
I'm
can
extremely
hear you.
sorry. The climate is not good in Bangalore. So that's why I was worrying, but so far so good. Let's see how it goes. Okay, I continue here. Okay, so I stopped here. So I was talking about the care. I'm not able to see the side things. It's okay, no? You can see me, right?
Yeah, we are seeing.
Yeah, fine.
Right.
So the care I was talking about to the mother, and the extent to the extent the mother has to be in abroad. I'm talking about actually not in India. So the care of babies will develop if the care is given through mother. For example, if the infant stimulation or if the massage has to be done, if no the not massage, basically it's a touch we call infant massage. So if that has to be given, it can be given through the parent so that it is more emotionally attached. Also, also just a minute. Yeah, that's right. Also, it is no, they follow the rules properly, compared to we are not undermining or blaming any of the medical people, but of course they follow their cleanliness hygiene. But these people are supposed to do, because to improve the survival rate of this, and those, so religiously they will do it. That is what they thought, and they are doing work on keeping the mother's bed next to the NICU. That is what the extent of the care, the importance of the well-being of the mother. That is why this OBG is very important here. And next comes that the mother, I spoke so much about mother. Mother is a part of this team actually. So it is like the care what we are giving in NICU is through the mother or through the family. So we call client-centered practice. So through the family only we are giving the intervention to infant. Of course, some of the treatments are directly given, but through the mother works much better for a longer result, and you can cover larger population. And next is about other specialities. So as the neonatologist, you will have other pediatrician coming in, and you have ophthalmologists, because children with preterm babies will have lots of retinal issues, and congenital anomalies and blindness are there. So ophthalmologist is an important person, and then early screening for hearing has to be done. All these things are very important in neonatal ICU. Even we have specification like how much sound we can make in NICU, like what is the decibel of it. Every specification is there. We can cover it in the next part, next session. And next comes these people, like you can see in the down one, right? Physiotherapy, occupational therapy, speech and language pathologist, and a psychologist. So, right, when you talk about a team, okay, so what our observation is, whatever you do for these children or infants is not adequate, because as a father, as a mother, I am always expecting my child to be better than now. So that is what the next level we are looking for. So the clear sharing of responsibility and executing the plan and bringing a whole individual is our responsibility. That is why I feel all these people has to be a part of the infant think. This is the model which I created for starting a center in one of the hospital, starting a neonatal ICU service in one of the hospital in Bangalore, but I didn't get a positive feedback from them, or because still what I heard is we are doing all these services. Oh, basic stimulation, we are giving. Positioning, we are giving. So this is what the response I got. So again, I have to go and prove, and I have to talk to them, allow me at least inside, and then we have to take some time to prove that we can do something. That is how we enter. But two scenarios. One is like if you go to a place and where NICU is already there, and then when you get into that, you get a challenge, then you are struggling like the previous history, and then you are creating an awareness about occupational therapy, and later generation will benefit out of that. And the second scenario is already established, like for example in St. John's, when I enter, it is already established by my former therapist, occupational therapist. They took the pain and they developed it. I just went and learned it. That's it. So that is how these two scenarios. So when I enter into the second hospital, it was a learning experience for me, so that I have to prove. And then later, once you prove that your role is very important, they will definitely behind you, for your support to these infants. Can we go to the next slide? Yeah. Now I am coming to the next part of it. Just a minute. Yeah. So as for my observation, right? So I divide this NICU role and NFC role, neonatal follow-up role. So I just divide it into two. So anything you see it forward to backward and backward to forward. Back and forth, you have to see what is happening, right? If you do something on neonatal follow-up, before that, I tell you what is neonatal follow-up. You know what is NICU, but what is neonatal follow-up? Neonatal follow-up is done after discharge from the neonatal ICU. So once the infant is discharged from the neonatal ICU, then the baby has to be followed up for their normal development with a group of professionals that include the professional which I have mentioned earlier. I think I missed a nutrition specialist actually, so that's very important, nutrition. So I missed that in that. Okay. So that is how I see. So we usually follow up to 2 years. So I put the primary goal as within 2 years, the maximum improvement, if possible. That means mainstreaming the child. That is what the idea. So now, when you say what is the role of occupational therapy, then this I formulated for that, the proposal to the neonatologist. Two aims I put forward. One is to define the most effective early intervention practice for high-risk infants in NICU and neonatal follow-up clinic. All right. Now, if you say that, okay, fine, I will manage without occupational therapist. Of course, you can manage, but you are adding a service to improve the quality of thing. So when you say early intervention, so how early we can intervene to prevent the complications from the neonatal ICU itself, so that we can carry over the developmental milestone in the neonatal follow-up clinic, get into mainstream, and then follow up till the childhood stage, or even after some time, actually. All right. The second thing, can you hear me? Hello?
Yes,
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 sir.
sir.
Yes,
Can
sir.
you hear
Yes, sir.
me?
We can hear you.
Yes,
Sir.
Ganapathy. Yeah, continue.
Yeah, fine. Thank you. So that is the idea. So how early? So we call early intervention. So how early? That is what the question. That I'm just leaving it to you. How early you want to start it? Especially to students. To create the interest towards looking towards this neonatal ICU, and how to get into that. Are we equipped with that? If they allow us into neonatal ICU, what we can do to these infants? These things are the questions uh, we are, I'm keeping in front of the young generation. So that's the second thing is, the second aim is to integrate the high-risk infant to the mainstream. So this is a very, very challenging situation. If the baby is stable baby, okay, well-born baby, only the problem is like preterm baby born around 2 kg, and then somehow they will develop and then get into normal mainstream. But this high-risk infant has to be picked up very, very early as possible. Like even no autism, they are trying to find out as early as possible. So this high-risk infant, if they screened as early as possible, the potential for future generation, the potential, the ability and the level of functioning of future generation will be much, much, much better. The burden on the family will significantly reduce, because by the time they come to neonatal follow for about 2 years, they will be well equipped with the developmental milestones, like how they have to handle, they will be like fully equipped with that. So no, you will be side by side empowering the parents too, right? So that is the second aim I put it, to integrate the high risk infant into the mainstream. That is, mainstream is like, we can call mainstream again, no, like normal children, integrating them into normal children and make them as a part of it. So the stigma we are facing is like, one is, when if the baby is having an abnormality, or no, like differently able or special children, we call a differently able children, still the stigma is there whatever the education is done. So it's like really challenging situation. People who work with children are very well aware of it. That is the second aim I have put it. Second then, next slide please. Now the goals. So as an occupational therapy, what are your goals? So the first goal is to prevent and minimize the effect of developmental disability in high-risk infants. So any in high-risk infants, of course, all these preterm babies, and like sometime what we have observed, preterm babies, we may develop normally, but in later stage, they develop problems related to learning difficulties. There's something called hypermobility syndrome because of the poor tone, and their ligaments are ligament laxity, uh, means loose joints, no, hypermobile joints, which cause some functional issues. um, we call it like poor integration, no, like I suggest to you, students, please go through no developmental milestone. And but when I suggest like the developmental milestone, I always suggest you read from uh, the sperm and ovum when they meet, no, from then you have to start reading that. So how the zygote form, how the ectoderm, endoderm, and mesoderm forms, and then how the nervous system forms. From the nervous system, how the nervous systems are dividing. No, what is the forebrain, hindbrain, midbrain? No, how it is coming. No, all these things. No, how it is developing, how this spine is developing. These things are very, very, very important for you to understand what is happening in the developing children. So in pregnancy, we divide that basically into three major uh, uh, what segments. First segment is like first trimester, and the second trimester, and third trimester. Uh, Overall, if you say the first trimester is the formation time. For example, if you say about 21 days, the baby's whole spine is formed. Um, and about 3 months time, the baby's whole body is formed, and the central nervous system is formed, and then it start connecting to each other, and no, it start sending the nerves to different part of the body, and connecting is happen. And then the third trimester, that unknown things, sproutings, lots of mechanisms are happening in the third trimester. In the third trimester, the emotional well-being of the mother and the mother is very, very important for the well-being of the baby. That is why in seventh month there we are sending the mother to their mother's house, so that we assume that she will be happy, so that the baby will be healthy. So that the third trimester is something called integration, what we call about sensory integration. All these things are actually beginning at that time. So the prevention and minimizing effect of developmental disability in high risk infant, we have to have a clear understanding about this development from the conception and till the actually the death. That is how the development happens, right? So next, to reduce the duration of NICU stay and early discharge. This is one aspect we can really make a huge change, because it has a huge financial impact or burden on the family. And also the hospitals are very happy if you discharge the children early, because the first 15 days to 20 days are the crucial time for working out. After that, the care is somewhat shifted to like it can be done even without hi-fi equipments. So the discharge early discharge is very, very, very important. So if we can integrate some of our technique into neonatal ICU, so the baby's weight gain can increase, nutrition, sucking can increase. So we are going to talk about sucking in the next, the nutrition part and the swallowing part in the next part. So these things are our role, so that the baby can be get discharged from the neonatal ICU as early as possible. And third thing is to reduce the caregiver burden and stress. Yes, that I just want all of you, like you handled baby, like if you are not married also, you might have undergone this emotional situation, that when the baby born, you might have witnessed that if the baby born with a with a with a problem, uh, immediately after the birth, what the mother expect or the father expect is the baby has to be next to them. But in this situation, what is happening, the baby is taken away and kept separately in ICU. Even we are not able to tolerate an adult to getting admitted in ICU, but if the just born baby, like if it's get admitted in ICU, just imagine the stress, the burden and the stress the mother and the father and the extended family members undergo is like, we are verbally, it's very difficult to express it. Um, why I'm telling is like, after all, what we are doing is like to make the feel good factors, like for people to feel good about their life. That is what the ultimate goal. How we can help them to feel better and to reduce the stress. That is the third important factor. Next, the important goals. Next slide, yeah, objectives. Okay, so how you can do that? That is what we are going to talk in the next this thing, next um, part. So objectives are what you can expect these things, like screening the neonate to determine the domains of therapy. So you have different domains of therapy as a department wise. Also, component wise, you have domains like you have the stability of the patient or the infant, and the growth and the development of the infant, neuromuscular integrity of the infant, psychological or behavioral organization of the infant. All these things are very, very important. For the students, I am telling, I think most of the therapists know about like about fair idea about it. But for the students, I'm telling you, even a just born have a lots of emotional thing. Their nervous systems are not so mature to be more contented. So the ultimate goal for these infants is make them more content and sleep well, sleep more. They usually know they like sleep up to 22 hours in a day. 22 hours, 20 to 22 hours they will be sleeping. So when we go there, I tell my colleagues or juniors or students that if you are going there and if the baby is sleeping, you should not give intervention, because you are giving intervention for the baby to sleep, not drowsy, but sleep, active sleep. So you have to observe the baby in active time. So the baby's contented and sleeping is very important. So determine the domain, what actually you are working towards. What are you looking for? Is it related to muscular or it's related to psychological components? So this is what the first objective. Second thing is domain specific assessment and interpretation and findings is the second objective. And you should have a specific assessment. As I said, in India, getting a standardized assessment is difficult, but we can have we can formulate assessments and execute that and see how we can help these babies. Um, of course, some of the hospitals and some of the medical colleges uh, who are running NICU should have all these standardized assessment, but not all the ICUs, not all neonatal ICUs. Next point is
Hello? Hello, Jonathan?
Mom?
He left or he's still there?
No, no. He's still there, Mom.
Hello, Ganapathy?
Ma'am, I think he left.
Okay, I'll check out. Okay.
He left, Mom.
Okay. So sorry for the inconvenience. We'll check it out and I'll be back.
I think his network is not good because of storm.
Hello? Okay, okay, okay. Hello? So he is signing in again and we'll have around like 15 minutes more. Then I think he'll be completing the session. After that, we can go on with the question sessions.
Dear participant, kindly bear with us because the resource person side they have some climate changes. So due to the network issues, he unable to continually present the presentation. So another few minutes he will join and continue the presentation.
is it audible?
Yes, sir.
I'm sorry for the interruption. So we stopped here. Yeah. So the last one is third one we are telling about. So through family-centered approach. That's what that client-centered and family-centered approach is the third part. And the fourth objective is to prepare the infant and the family for discharge and to plan for the regular follow-up in OPD basis. That is for neonatal follow-up cleaning, I mean. So because if the baby got discharged and went to home, but we have the responsibility to screen them for at least for 2 years, 3 years, and integrate them and keep in touch so that they can contact you later for their developmental needs. So this is, I feel that it is like as an individual therapist, as an organization, we have to give more focus in this thing to keep the client in our no contact, so that we can help better even extended care. Like see what technology has brought us closer. Like I'm talking to almost 150 people at the same time. It's a good thing, but we can do like these kind of things in future to cover most of the population. Majority of the population we can help. So that is the fourth objective. I put that prepare the infant and the family for the discharge plan for the regular OPD follow. That is neonatal follow-up clinic. Okay. From then it will start their developments and things and all. But actually what you do in the neonatal ICU is you are preparing the baby. That is what the intervention is. Not like go and do intervention, because we have I tell my people who learn from me or students, uh, we are always hurry to do something, uh, start intervention, but what I feel is the observation skill is the most important thing for the therapist first. So you have a keen observation in this neonatal ICU. The keen observation is very, very important, because the subtle behavior they show, the infant show, has to be picked up and followed up. For example, if you will be touching the baby, but they pass motion, but shows that the baby is undergone hypotonia, sudden loss of tone, hypotonia. They just go motion, no. So because the activeness has come down, so there is a physiological change happening. So these changes, color change it could be, or they're doing some of the physical cues which has to be picked up. So the therapist should be very sensitive enough to pick up all these cues and give your intervention. That's why observation is very important. So though you know, like if you are treating the baby, you're doing good to the baby, that is important. But more important is not harming the baby, harming any of the patient. That is the primary thing which we have to understand. So observation, assessment, and then intervention in a very, very gentle way is the key here in neonatal ICU. Next slide, please. Yes. Now, I also, before get into the next part of it, like, it's not only in neonatal ICU, like any ICUs, like when we go, like it's my personal experience, like sometime that you, for the therapist, it may be like, it may be wrong, but it's my perception. Okay. I feel like, okay, something restricted. Because you have therapies which are like more movements and things should happen, they have to follow. But even in neuro ICU, patients will be in a very ill state, where we go and do some therapy, which is which is of course very, very important in the early stage, but it is not very friendly environment to do the therapy, because it is like they are looking up to the survival first. Okay, the survival is important. At the same time, the life is given by the intensivist, and when you go and collaborate with them in a very, very gentle way, it will be very beautiful, I feel, because you help them, they help you, like that. This kind of collaboration should form. That is the medical people and paramedical people. Or medical people, I mean to say that the people who are already there and people we are going from outside has to have a nice collaboration, so that the baby is the center point to serve the maximum. So the stage one, it's like a stage one, the four stages. So first stage is that independent consultation. You will be called, you come and assess the baby, and then you will be working with them and understand what is happening there, and talk to them and be friendly, and help them doing their work, and they will start helping you. Then it will become a no co workers competition, and sorry, competence, and then that the bonding develops. Just start, the interaction develops. Then you, as through your work, you build that trust, and the trust, and slowly you will just join in the care towards the infant, and you will be a committed partnership with the peak creative experience. You can create, you can put all your creation into neonatal infant, look up to what you want to get out of this infant, what we want to get out of this infant in future can be started as early as possible. That means I mean to say 23-week post-conceptual age. That is what the real early intervention. Hmm? Fine, then next slide, please. Okay, so I just thought, no, like the before maybe like when we were studying, what we were doing is if someone says incubator, then we have to imagine, oh, incubator is like that. Okay, and you say heart or up. Can you hear me? Sorry, can you hear me?
Yes,
Sorry.
yes,
Yes,
we
yes,
can
Yeah,
hear you.
yeah, yeah.
yes, Ganapathy.
When you say heart, we have to imagine. So I feel in this present generation of students I'm not able to tell it clearly. Is it a strength or weakness? But the imagination is. You if you want to see heart, you can three-dimensionally you can see the heart, and you can wear a virtual glass and see the heart, right chamber, left chamber, everything. But when we were studying, we have to write a line diagram, and then we have to create the 3D dimension, and where is the heart, and behind that what is that side, what is these things actually. So that is one thing I wanted to keep it in front of you, that so that is why I didn't put the no, the imagination that how it was like about 300 years back, how it was, and then now what we are facing. It is developed in 19 not 9, the first time with the with the heat generator. This is the incubator, the first incubator created with vaguely, like you can't see from the sides and all, but you can see fairly this front side. The next slide, please. Yeah, this is the person I was talking about. Mark Cuny is a wonderful person, but frankly speaking, I didn't read this thing before, like, but I have to present this for people. So I just thought, okay, let me read about this, what he has done, what people worked behind this neonatal ICU. It's a time that thanks for this opportunity to understand this. So this Mark Coney, that is, his name is Martin Coney. He is the one who showed us experiment, right? That this is the picture of this incubator, and he kept the babies inside that. Okay, and next thing. Yeah, this person again exhibition he has done in 1909. I was just imagining that, imagine the exhibition and do the nurses holding the infants and showing them, and they were coming, and also no, like when they were transferring these babies, some fire accident happened with him, and he has to face, but he rescued most of the babies, but some fire accident happened for that also. He's the one, he is the one who lost his reputation badly for this particular field. No, to bring this awareness. By the time everybody start accepting it at 1950s, he passed away actually. So the next slide. Yeah, this is the a little modern incubator later stage. It with transparent glasses, so you can approach the baby from the side and give the care. Next slide. Yeah, this is the present neonatal ICU setup. This is the maximum thing is happening now at present with all facilities and high-tech equipments with the maintaining the airway monitoring and heat regulation. See, even for the students who have not seen this, this is the you may have some neon lights for therapy, neon lights for therapy, and then you have a radiant warmer which will give heat to these babies. All these are present advancement. Next slide, please. Yeah. So just I put this picture to just understand that what is the state of these babies are very fragile, and then this is one of the baby position that, so you can see this W hand position. All these things are our role. Like usually the flaccid babies, they'll have something called W hand position and M leg position, like this. M leg position is abducted, so it has to be positioned properly, and then the neck has to be supported properly, and the hand has to be kept in midline. All these things are your understanding, like what is very important for this, because this midline orientation is important for the baby. They have to keep, they kept in, they have, I'm sorry, yeah, is it okay? Yeah. So they have to be kept in the flexed position, so that is the protected position. The compared to the volar aspect of the body, the dorsal aspect is more, more, you feel more secure. That's why when someone is coming to beat you, show your back, not the front part of the body. So it is also that the extended posture can also expose so much to cause heat loss, that we are going to talk detail in next session. Next slide. Yeah, you can see this. One more thing is like this nasogastric tube or oral tube, which is placed on this. For this, I was talking about this through tube, tube feeder. You might have seen this in adult also. Yes. Next slide. Next slide, please. Yeah, that is the end of the session, part 1. So I thought, like, let me give you an orientation. I feel that this is fair enough for you to understand what is it. And but here I have seen lots of senior people, and my contemporaries and my students and juniors are there, but it's a more diverse population. So I was just confused, like how to create this slide, but I wanted to give a orientation, of course. What is it and what is happening? What we have to look forward to do something about it. That is why I put all these things. And one more thing I'm sorry about is I like the seminars or classes, looking at the people and get their feedback and talk to them, but it's not possible. I'm just seeing the screen and talking, sitting alone and talking. So that was the disadvantage. That's okay, but it's a good experience. Maybe probably next time I can do a little more better. I feel. Thank you so much. And this is a question session. I just mute myself. If anybody wants to ask some questions, you can ask.
Okay, this is a question session now. So participants, kindly unmute yourself. You can come up with your questions. One at a time.
Participant can type your questions also.
So no doubts. Everybody is very clear, I think.
Yeah, also you can write your feedbacks so that based on your feedback, I can prepare the next session, like what you understood, where I have to focus more. It will be useful, right? Infant have issues in sucking. So what is their role? That is what I'm talking about. Okay. Next, that is, how an OT can help in discharge planning. Good. Okay. So these are the things I am planning to cover. Still, I answer the first question. So how do you look at? No, the question is: infants have issues in sucking, and so what is the role? So before answering this question, I would suggest you to go through synactive theory of development. Synactive theory is talking about what is happening in the baby's development, like which month, which week of intrauterine life, what reflexes are developing. So if you talk about sucking reflex, it's developing around 30 to 32 weeks. The sucking reflex is developing in the intrauterine life. So you have to wait until 30 weeks for the reflex to develop. Before that, we cannot start this intervention. So these parts I am going to cover in the next part. Don't worry. Okay. So how deeply, because no, we cannot just go and give the stimulation, but we have to understand the physiological background and developmental background behind that, then start the plan for the this thing. And then next question is how an OT can help in discharge planning. Yes, of course. Now, yeah, 1 minute. Just a minute. I'm getting a lots of questions. What should I do? I have to go one by one and answer it right now.
Yeah. Yes, yes.
Yes, no. So I
Yes,
have
yes.
okay. Yes, okay, fine, fine. So the second question is okay, how an OT can help in discharge planning? That's a good question. Actually, the discharge in neonatal ICU is decided by the baby has to be sickness free, their vitals should be stable, and then, excuse me, vitals should be stable, and they should have at least minimum weight of 2 kg for tolerating the external environment, because otherwise they will have cold stress complications. So the interventions are focused towards that irritability, to reduce the irritability, improve the sleep, and increase the weight. That is the most important thing. So the goal, increase the weight, and yeah, the sickness, and that parents are ready to take care of the babies uh, alone at home, then it's good. Now there is something called swaddling technique. You cover the baby with a cloth, right? So to prevent the heat loss. So these things we have to emphasize and uh, evaluate them further and make sure, okay, from your side you can give the clearance for discharge planning. Is that the answer for you? Okay. And next is, sir, please explain how OT can help in high arched. What is that? You mean to say palate, right? Palate. Okay. I was just a minute. I see that. Yeah. Yeah. Here is a question. Yeah. High arched palate. Okay. So palate is like in infant. No, the palates are soft, and it is the arch of the palate is important for the baby to suck against the what do you say, that the tongue, the baby has to suck the nipple against the thumb, but this is a structural anomaly that has to be evaluated, and that has to be evaluated and then addressed properly. For this, we need to do a proper sucking evaluation, and then the intervention has to be planned. That will be addressed in the next session. Like I told you, the dysphagia management, like how you have to go step by step to facilitate extra, what do you say, that perioral stimulation, and then go to intraoral, and then facilitate the sucking and swallowing, breathing and swallowing coordination. All these things are the part of this. And the high arch is a structural anomaly. I feel then it has to be addressed in a different way. The next question is, yes. Yeah. What is the specific technique and the most appropriate technique of oromotor stimulation? Again, the same question I will answer the next time. What the really, I don't know. I just read about it. What is this called? Beckman oral stimulation. Shivam has asked about it, and I'll just read about it and get back to you. And yeah, what is this? Range of motion and tone, that also will be covered in the next session, but give you a small clue. The babies have something called fetal angles. Based on that we decide their no range of motion. The fetal angles are initially no less, and gradually it has to increase. That means the flexibility has to increase. If the initially itself, that if the birth itself the flexibility is more, then it is hypotonic. The preterm infants are mostly hypotonic, and they are like against gravity moving their body is very difficult, so that they will have the extended posture, body will be like the W position. So the tone is like hypotonic at that time in preterm babies. And babies with the brain injuries like intraventricular hemorrhage, they may have a hemi or all the four limb involvement, and the spasticity. I mean, spasticity can be there. So again, it is not range of motion, but we call that angles, fetal angles. There is something called scarf angle, popliteal angle, ankle TA tightness, and heel to ear. These kind of assessment strategies are used to assess the range of motion and tone. And next is, what should be the documentary or documentary? I don't understand what is it, but I will cover that. It's documentary or set. Yeah. Next question is, what is that? Decimetry, yeah? Okay. What's our primary intervention for? Okay, there are lots of questions related to oromotor, so I feel the next part I have to cover oromotor very specifically. Of course, we have a very good role in that. I will try to put lots of details into this. Okay, NOVAS is a one scale which is used now in other countries, but it has to be trained, because frankly speaking, I'm not trained, I'm not certified. I'm not certified to any of the neonatal assessments. So NOMAS is one scale that is which you have to get certified to assess the neonates feeding abilities. Can you repeat the role of OT in NICU? That I'm going to do the next session actually. What I have planned is, what are the different areas we have to cover. That is what I'm going to do as next told. The next part means next meeting. How we can support babies' sense in NICU child and the good. That is a good question. Actually, this is what I want you people to understand. There is something called, you can refer your books. What is the difference between intrauterine life and extrauterine life? If the baby is born before, what are the emotional and physical sensory experience the baby is going through is very, very important for us to understand what we have to do with the babies. You observe everywhere like what kind of treatment is going on is like, everybody started moving friendly treatment procedures, giving more importance to the psychological component of the child development. So what the baby feel, you have to have a empathy to understand that. That is what the idea or crux of this treatment plan here. So you have to understand the basic difference between the intrauterine life, how the baby feel inside the womb. When you hear the sound, how it will be, but when the baby come out, you are talking louder in ICU, how it will affect the baby. When you touch, how it is going to affect. If your hand is washed and directly you are going and touching the child, your hand will be cold, and how that is going to affect the baby. There will be lots of heat which is conducted through your heat to cold, no cold surface. So these things are very, very, very minute area. I will say more than intervention, you feel that you have to have an understanding of this baby's feeling, then your intervention is molded very well. Of course, the FRI is a sensory based and neuro motor developmental frame of reference. Sometimes you use biomechanical frame of reference for splinting and positioning these things, and you have a huge developmental frame of reference has to be used, and you have a lots of environmental modification has to be done, and how this communication, how this client center work, all these things you have to conduct parent group. All these things are the frame of reference which we are going to cover in the next part. If the infant having associated disorders like autism and Down syndrome, they will be any difference in care for them. Yes, of course. Yeah, these, right, autism they are trying, even in St. John's when I was there, later also they are trying to create scales to evaluate the infants, evaluate the autism, that means screen the autism as early as possible, that is before 2 years. I was called for this group discussion. What I understood is like in autism there are signs which can be picked up. It's a spectrum disorder, like no, it's not a one specific disorder. That if you are talking about autism, that it takes a whole 2-3 days to talk about it, how we can deal with this thing. But if you can detect it as early as possible, the sensory integration and the behavioral modification positioning could be done as early. Behavior modification and developmental milestone can be implemented as early as possible. That is why they are focusing on this autism and try to create this thing. There are people who are thinking about what is the gut-brain relationship, what is happening. The whole lot of research going on, how to treat the gut to improve the quality of life of autistic children and improve their communication and brain integration better. The next question is sorry. Yeah. You said we shall give when the baby is awake. What if the baby is under medication or sedation? Can we give them our intervention? Yes, you can give your intervention through the parents. That's what we were talking about. So here, like majority of the time, what happens? Like when we go, the baby will be sleeping. So if the baby is not a very sick baby, not drowsy stage because of the medications or any medicines which causes drowsiness, then it has to be dealt differently. But the primary focus is make the baby comfortable there in NICU and make the parents comfortable and prepare them for the discharge. So after discharge, what they are going to do, how do they position it, how do they move their joints, all these things are very important. Active participation, yes, you have to observe the baby when they are sleeping and when the baby is awake. And also you have to have a clear communication with the parents and nurses to understand their sleep routine, and when the baby will be alert, then you have to understand that, then you have to go and observe for the wake, means that the alertness evaluation. Otherwise, if the baby is sleeping, it is not recommended to do the therapy by disturbing the baby and do some exercises or moving the part. What are the type of stimulation on OT scan provided to newborn will be covered? What is the level 4 NICU? That is what I was talking about. Neonatal ICU in India, we have only level 3. That is what, then the because of the challenges related to a financial thing. But Other countries, if you say that it is for level 4 NICU means, in US, it means that maybe they have even the transportation system, adequate facility, adequate uh, ventilators, and life-saving measures are adequate to provide. Especially know that the transportation is very challenging. Like you should have a moving ICU to take one place to another place for the baby. So that is what the level 4 NICU means. And so how to handle an infant if they are okay, correct. Yeah, this is a good question. Actually, I will deal with this saturation level. If it is low, yes, the saturation has to be maintained above 85, but 90, more than 90 is the best saturation level for infants. If the saturation goes down, some overstimulation is happening, the pulse rate should go up and the saturation should come down. So what we can do is, what we have observed is that putting the baby in the proper position can increase the saturation level, make the baby more comfortable. That's what, like when you observe the thing, the vital signs are important thing to observe. Uh, what we have observed is, if you put the baby on the right side towards that and flex their arms and legs, the babies are better responding at that time. The saturation goes up compared to us the left side. And there are indications and contraindications related to position when you see the changes in the saturation, and if the baby is having respiratory distress syndrome, what you should not do, what you should do. And if the baby is having cardiac problem, which are the position you have to avoid. All these things are indication and contraindication we have to understand. After all, if you understand what not to do, is the best thing for a therapist to do in the NICU. That's what I feel. And also, the idea is to increase the saturation. You have to check all these vitals, and then you have to give them the comfort. Sometimes you can encourage non-nutritive sucking, that is taking the baby's thumb into mouth, so that the sucking itself soothes, that you have the oral area have a highly connection with the parasympathetic nervous system, is calm down the baby much better. And what we can do for sensory deprived neonate in ICU? Yeah, sensory deprived neonate is like in what context? That's what, yeah. Sensory deprived neonate. That means if you are not giving the sensation, the babies will become sensory deprived, or that is what I wanted to understand. Can you please explain that? What is called sensory deprived neonates in NICU? This is Jasmine. Okay, I'll just think about it. Okay, sensory deprived neonates. Yeah, Jasmine is there. Okay. Next is because what we are doing is sensory enrichment therapy, a kind of sensory enrichment therapy. So we are trying to improve their sensory awareness, and what is the appropriate sensation has to be given. The threshold has to be understood, and the therapy has to be given. Okay. And where am I? Yes. Now, do you believe in music therapy works in NICU? Yes, of course. Music sung by mother, father, sibling. Yeah, I forgot to say sibling also in other countries. Sibling are also allowed to do KMC. Sorry, kangaroo care. If the mother sing, it's much better because they have an emotional connection with them. But excuse me, just a minute. I just connect my laptop. Charges. Oh, current is not there. Sorry if it get disconnected in between. Binsi, yeah. So how I can? Yeah. Because the yeah. Tell me, sir.
Yeah, actually, mostly are intervention questions. Maybe next session after your intervention part over,
Yeah, yeah.
It may be useful for the other audience also.
Fine, sir. Fine, sir. I just go through. Can I go through all these questions again later, or I have to copy paste it? Can I?
Jonathan, can you screenshot it? Can
Yeah, yeah.
Jonathan or Jonathan?
We can do
Okay,
screenshot,
ma'am.
Ganapathy.
Yeah. Just a
And
minute.
we'll,
Done you.
Doing it. Please shot it and then send it to me so that I can address all these things. And also you can give your feedback how you want the next session. So I can try my level best to make it useful.
okay, now so we will end up with the question sessions. So after the next case lecture, I think he'll be explaining about the OP management in NICU. Then all these questions can be addressed more clearly. So now I request Dr. Arun, Principal, Savita College of Occupational Therapy, to render the word.
Thank you, Binsi. First of all, I thank our alumni, Dr. Ganapathy, for the wonderful presentation. He voluntarily accepted for the presentation. It's a nice presentation. Just I have seen in Facebook reviews and all. They are very good. It was very useful presentation. So I thank our webinar coordinator, Assistant Professor Dr. Binsi John, and also the student officials, those who are helped for the conducting the seminar, and all the participants. I thank all the participants for the passion and the attending. And we give certificate for uh, next session. So we have intervention part also is very important. So after finishing the intervention session, we will commonly giving the certificate. Okay. So thank you very much. Thank you all. Thank you, Ganapathy, for the wonderful session. Yeah, Vinci?
Yes, sir.
Yeah. You can
Yeah, we'll
wind up.
wind up. Yes, sir. Yes, sir. Okay.
Ganapathy,
Hello, Ganapathy.
is there? Or switch off?
Jonathan, he's there or he has left?
Oh, I think.
Yes, left, ma'am.
Okay, sir. Okay. Okay, then we'll find out.
So can I end the meeting, ma'am?
Hello?
So meeting
Okay.
ended.
Okay. We are closing the session. We'll meet again the another time for the intervention session. Thank you all. Thank you.